Now it's my pleasure to introduce Dr. Lee Kawas, who is CEO President at 3M Biotechnologies. Oh, I'm sorry, M3 Biotechnology. Leen has been featured in 2 previous leadership conferences that we have done, and she's been so compelling that actually one of our attendees stepped up and financed one of her last ventures. Dr. Kawas has led M3 Biotechnology Group since 2013, following completion of her PhD in molecular pharmacology from Washington State University in 2011. Leen has led the company in business and financial growth through 2 oversubscribed financing rounds. The funds raised will support and accelerate growth of the company as it takes the lead candidate to early stages of human testing. For her leadership and accomplishments thus far, she's won many awards. This includes Ernst & Young's Winning Women Entrepreneur and recognition for M3 as one of Seattle's top 10 hottest startups by Keire. Now it's my pleasure. Rhonda is going to introduce the panel, and Dr. Kawas, it's all yours.
Thank you. Okay, so today I'm going to introduce 3 very interesting people that will talk about fusion of technology and medical advances. And I think Seattle and the greater Seattle area is a very interesting place to fuse these 2 together. I'm going to start with Dr. Paul Keire, who worked for a number of years in the Department of Pathology and Biological Structure at the University of Washington, and is now with Anatomy Next. Very interesting. They are developing tools to teach anatomy to medical students and to provide interactive tools between patients and physician. Communication, I think, is very important, as we heard this morning. They also have pre-surgical simulator and teaching tools using Microsoft HoloLens technology. Other achievements for Dr. Keire includes founding of WAN Internet for the country of Latvia, and a number of publications, recognitions, and awards in anatomic studies, tissue engineering, and cardiovascular medicine, musculoskeletal disorders, and others. He did his undergraduate studies at the University of Washington with degrees in chemistry. He also received his medical and PhD from Ohio and the University of Washington. Rhonda, Rhyne, CEO and board director of Prevencio. Rhonda is also a friend of mine and one of my advisors here in the area. A very impressive woman who has over 20 plus years of C-suite medical technology experience. But Prevencio, her company, is in Kirkland and is developing multi-protein blood tests for obstructive heart disease and 1-year risk for myocardial infarction, stroke, and cardiovascular death. She serves as a board director for Aminex Therapeutics and Autonexus Medical Technologies. Both are Seattle companies. And as a medical technology industry leader, she also received multiple awards. Entrepreneur of the Year for Ernst & Young's, Fast 50 for 50 fast-growing technology and life science companies in Southern California, and many more. She also authored a leadership book for women, Keys to the Corner Office. It's available, I think, on Amazon and other places. Chris Brooks, who I had the pleasure to meet this morning, very exciting work their company is doing, is the managing director at Ventec Life Systems, creators of VOCSN, the first and only portable unified respiratory system. Chris has a diverse background in politics, government, corporate, and non-profit sectors, building innovative programs, often through the implementation of emerging technologies. Most recently, Chris was the Global Director of Corporate Affairs for Hilton Hotels, where he served in a cross-functional role, rebuilding the company as a private enterprise and bringing it back to the public market in 2013. Chris brings the same hospitality focus to Ventec with passion for patient-centric design. So with this, I guess we can start with Chris, who will tell us about the fusion of technology and advances.
Bear with us 1 second. Excellent. Good afternoon, or good morning. Good morning still. Very excited to be here. Very excited to talk to you about what we are doing at Ventec Life Systems. As you heard, I actually don't have a deep background in the medical field. It's very intimidating to be up here with a lot of doctors, a lot of very smart folks. But at Ventec, what we are doing, while we are in the medical device community, and we have built an innovative medical device, which I will talk to you about, we really see ourselves as much more than just a medical device manufacturer. Really looking at how we can infuse technology, build better devices, but ultimately create better patient outcomes. So a little bit of background about Ventec Life Systems. You probably haven't heard of us unless you are an avid reader of the Seattle Times. We were recently featured in there. We were founded in 2012 by Doug DeVries. Doug, who is our founder and chief operating officer, has been in ventilator technology for the better part of his entire life. He's been in the space for about 40 years, has brought over 10 devices to market, created the first truly portable ventilator for patients about 20 years ago called the LTV, which stood for the laptop ventilator. Most of you are probably familiar with Christopher Reeves. It was his preferred ventilator. To give you a little bit of context of what we're doing and the sort of patient population that we can help. So Doug is truly a legend in this space, was happily retired after selling the company that built the LTV, big aviation fan, moved to Washington State, really loves float planes. This is a great place for it. And really thought that he could do something more, and I'll tell a little bit more about his story and how he came about creating Ventec Life Systems. We're headquartered in Bothell. We have an ISO-certified medical device manufacturing facility. We do all of our design, engineering, development, assembly, manufacturing, front office is all done in Bothell. So an exciting, a lot of work going on up there. We've got about 40 team members, growing rapidly, and just finished our Series C round of funding for a total raise of $28 million. All of that really came from friends and family. So those of you not in the medical device space might not be aware, but while that is a big industry here in the United States, especially for life support devices, the early stage investment is very difficult to come by. So we have no institutional investment at all. It's all friends and family who knew Doug and knew that he would be able to bring this to market, and indeed that's what we have done. So to give you a bit of context of what we're trying to solve for. So this picture is probably very difficult for everyone in the audience to see, and intentionally so. You probably see a lot of tubes, a lot of wires, a lot of equipment. It looks scary, it's intimidating, and what you really miss in these four pictures are the four human beings that are buried among all of this equipment. And this, unfortunately, is the reality of a ventilator patient, somebody who needs a life support device to help them breathe day in and day out, every minute of their life. Whether you're in the hospital or in this particular contraption, they've tried to rig it all to a stroller so that they could take their kid out, or in a car scenario just to drive 10 minutes down the road and go to a doctor's appointment. Very intimidating, very burdensome, and this is the daily reality for hundreds of thousands of people around the world. Some medical conditions, if you need a ventilator, there's probably 4 main buckets that you would fall into. Neuromuscular disease, so ALS probably being one of the more well-known diseases, a terrible disease. Doug's father actually had ALS, elected not to go on a ventilator because he didn't want to be a burden to his family. He didn't want those pictures that I showed you to be him. And so he did not live long through the disease. And Doug was really inspired to say, you know, look, I created a portable ventilator that allowed patients to leave the hospital early and really kind of be mobile, and the reality is they're not mobile. If you have a spinal cord injury, you have no control of your lung function, you're unable to breathe on your own. If you have impaired lung function due to COPD or lung cancer, or if you're a premature child, oftentimes they'll be on a ventilator for a period of a couple months or a few years as their lungs grow. So a wide spectrum of people who depend on a ventilator day in and day out to breathe. You probably have a direct relationship to somebody who has at one point been on a ventilator. Typical equipment that they would need would be up to 5 different devices, and there's actually a variety of other devices that they might need as well. So obviously the ventilator itself, which is providing the inspiratory and expiratory process to help them breathe. An oxygen concentrator to create and deliver concentrated oxygen, because oftentimes they don't have the ability to absorb the oxygen, room oxygen like you and I. A cough machine, which in some parts of the country and around the world are more prevalent than others. But essentially, you and I, if we have a cold or allergies, especially this time of year, we cough to remove the secretions in our lungs. If you don't have the ability to control muscle function in your respiratory system, you have a cough machine, which essentially sends a big gust of air in, a big gust of air out, and mimics that cough. A suction machine then removes the secretions from your lungs so you don't get infections, and then a nebulizer, which basically takes medicine and turns it into a mist so it can be absorbed by the lungs. So all 5 of these devices are very complex. This is really the top of the line. This is as good as it gets right now for patients. We could show you other devices that were created decades ago, up to 3 and 4 decades ago, that are still in use today, and they look much scarier than the devices you're looking at right here. They all have separate power cords, separate batteries, separate tubes that connect the patient to the device, and they all have a different way of operating. So a very complex situation if you're on a ventilator. So enter VOCSN. I mentioned that Doug said he created a portable ventilator, and he really wanted to combine them, and that's exactly what we've done with VOCSN. So VOCSN stands for ventilation, oxygen, cough, suction, nebulizer, and it is exactly that. All 5 of these devices combined in one simple toaster-sized, 18-pound portable device with a very easy-to-use, intuitive touchscreen interface that works much like your cell phone and not like the complex, scary devices that you're used to seeing in this space. We say 55 pounds there. That doesn't include all of the extra batteries, power adapters, and accessories that you need to use all of these devices. So just on face value alone, being able to consolidate all of these devices into a single portable unit was a big step forward in this space, but really doesn't even begin to explain the entire story about VOCSN. Quick background about the device itself. We are talking about technology after all. There's over 490 unique parts in VOCSN, and 400 of them are very bespoke, custom-made parts. So it's not just as simple as kind of combining all of these into one unit. We needed to make things smaller. We needed to make them more energy efficient. We needed to make these devices work seamlessly together. And in order to do that, we couldn't buy any off-the-shelf pumps or screws or compressors. All of it had to be created from scratch. So we do that with 9 different countries in over 31 states that we're sourcing parts from, 28 of which are here in Washington. So truly a local story. We couldn't do what we do without the support of the other companies up in the Bothell area and throughout the Seattle region. We use a lot of 3D printing to rapidly prototype and test how the integration of all of these parts would work together. And we are very excited to say that we were FDA 510K cleared just this past April. So we are going on our first patients here in the next coming weeks, and very excited to begin to get their feedback. So what is VOCSN? Obviously, it's 5 in 1, but what does that actually mean for the patient population? We like to say it's 3 things. It's simple, mobile, and care-changing. On the simple side, it's really this idea of one. So of course we have one device, but we now have one device to clean, one device to manage, one device to learn how to use, one device to store, one device to get serviced. A very intuitive touchscreen operating system, again, that works much like your cell phone. A lot of what we did, both in the aesthetics and the look and the feel of the device, as well as how the operating system works, was informed by hundreds and hundreds of studies with both doctors and clinicians and patients, as well as people who've never touched a ventilator before, to see if they could understand how you change an oxygen setting or how you administer a cough therapy without having a deep knowledge and background. Imagine a couple like the one that you see here who has a newborn child, and that child has underdeveloped lungs and needs to go on a ventilator. Well, they're now stuck in the hospital until they can A, retrofit their home with the outlets to accommodate 5 separate devices, B, spend hours with the clinicians in the hospital learning how to use all of these different devices, and then C, have the confidence to take all of that home and be independently in charge of their newborn child. I don't have kids, but it seems scary enough as it is. I can't imagine bringing one home with all of this equipment and trying to figure out how to make it work and knowing that their life is dependent upon that. So first and foremost, simple. And really a lot of that revolves around the operating system and what we're able to do with the technology there. That also allows us to continually evolve and adapt. So as we're getting user feedback, we're able to make tweaks in the software to make it even more intuitive for patients and caregivers. VOCSN is mobile, so hopefully this is obvious just in the physical representation of VOCSN. It's 70% lighter and smaller than the existing 5 devices. It's 5 therapies in one, so you never have to worry about not having suction or oxygen while you're on the go. This has a variety of different applications. You can imagine even in a hospital setting, if you're transporting a patient from their hospital room to surgery, for instance, and you're in the elevator and the elevator gets stuck and you don't have an oxygen canister with you, and that patient needs oxygen, you're out of luck. And with VOCSN, every time you pick up that device and go, you've got all 5 therapies. So it really changes this idea of mobility and kind of turns it on its head. You know, a lot of the existing devices in the space talk about mobility, and we like to say you can put a house on wheels and call it mobile, but it's not actually mobile. VOCSN really takes all 5 of these devices and provides that everyday mobility that you and I have. If a friend calls and says, do you want to catch a movie in an hour? You can actually do that now with VOCSN, whereas before you would spend 6 hours preparing for the 10-minute drive to go to the doctor's office. So VOCSN really provides that everyday mobility. As we mentioned, making it more energy efficient and giving it 9 hours of battery life really gives you the ability to go catch a baseball game, see a movie, hang out with your friends, and live your life unimpeded by this device that is with you all the time. And then ultimately what that means is it's care changing. Really this comes down to the human factor, and that's really what we are passionate about. As mentioned at the top of the presentation, my background isn't in medicine. I actually came out of the hospitality space, and in hospitality we're all about making guests happy. And really that's what we're trying to do with VOCSN. We're not just trying to make a very complicated device that works really well and can gain FDA approval. We want a device that people are actually going to enjoy using and that's going to make a difference in their lives and improve their quality of care. So with VOCSN, you no longer have to switch between separate devices. Literally with the touch of a button, you can administer one of these therapies. What does that mean? Well, if you administer a cough therapy, just for instance, one of those therapies, you're breathing on a ventilator. This is what you depend upon to live. Literally every breath is drawn from the ventilator. In order to administer a cough therapy, you have to disconnect from the ventilator. You have to reconnect to a new tube for the cough machine. You have to kind of play this little song and dance with your therapist, kind of count to 3 and try to get it in sync, administer the cough, then disconnect from that device, likely connect to a suction device to suck out the secretions, and then maybe up to 15 minutes later, you're going back on that ventilator that you depend upon to breathe. So you can imagine that is a traumatic experience for a patient. It's also traumatic for a caregiver. Sometimes it takes 2 caregivers. Now, literally with the touch of a button, using the same circuit that the patient's already using, whether it's a face mask or a tracheostomy, they can literally press with the touch of a button and administer that cough therapy in between or in sync with the patient breath and go right back to breathing. So that alone opens up a whole world of opportunities as far as reducing the chance for infection. Every time you disconnect that ventilator, you're introducing bacteria and other potential infections. And then making the device quieter as well, so making it something that you can actually go to a movie and not distract the entire theater with all of your equipment. And VOCSN is just the beginning. So really today we're talking about technology and how technology is improving medicine. We really are focused on 3 key items. Integration, obviously integrating these devices, we think this is just the beginning, and you're going to begin to see more devices being integrated to match the patient where they are rather than the patient having to run to multiple devices. And doing everything we can to get the patient from hospital to home. We all feel very anxious in hospitals, and we all feel comfortable at home. So just by virtue of getting a patient home and allowing them to have hospital-grade technology in the home is a great, very helpful in providing care to these individuals. Connectivity, VOCSN has Wi-Fi and Bluetooth capability built in. It's currently not activated until the regulatory and security environments kind of catch up to speed and make that something that a life support device can use. But as soon as that is ready, we are ready, and VOCSN will have the ability to be remotely monitored by doctors, and you can imagine all of the exciting potential that that would have, perhaps a patient not even ever having to go back to the hospital, but being able to have that doctor interaction in their home with VOCSN. And then personalization. VOCSN can be configured so that you only have 2 or 3 of the therapies if needed. And we think that this is just the beginning of where we can go with personalization. There's a lot of voice-activated technology out there right now. I can use my voice to turn the lights on in my home or to turn my coffee pot on in the morning. We believe that soon patients should be able to say, Alexa, activate cough, and the cough therapy is activated for them without even needing the caregiver necessarily to be part of that, what is now a 15-minute process. So we're very excited about what the future will bring, and like I said, we're going on patients here in the next couple of weeks, and look forward to sharing their stories about how VOCSN is changing their lives. So, thank you.
Okay, maybe I could ask you a question, Chris, before we move to the next one. So you mentioned earlier that all of the funding was from friends and family, and that you had support from other companies in the Boston area. And I think that we are in a very, very unique area where technology itself is very strong. I think biotech is catching up with the high-tech industry here. So how did that affect your company to succeed here and actually get a product approved in 7 years only? That's like very fast in clinical trials. So congratulations on your approval. So.
Yeah, like I said before, this area has been wonderful to us, and we would not be able to have VOCSN at all, I think, without being in this area, relying on both the talent, the engineering talent in this area. We have 40 of some of the smartest engineers, if not the smartest engineers in the field of respiratory care. Based here in Seattle, a lot of our partners that we've relied upon for building the device, a lot of the friends and family who have a personal connection to respiratory care and improved patient experience, who invested in Doug's idea 7 years ago, which became Ventec Life and has now formed into VOCSN. So we still struggle to get software engineers. There's a lot of competition for software engineers, as you might be aware, in this area. And we are constantly hiring, so if you have anybody who is an engineer or anyone else who is excited about the future of technology, particularly around medical devices, and has a passion for improving patient care, we'd love to talk to you.
Perfect. I guess we could move to the next speaker on the panel, Dr. Keire or Rhonda. It doesn't matter. I guess we could go in. Yeah, go ahead, Paul. I'm the moderator, Paul.
Thank you so much. That was very kind. So, I like to always use the phrase, now for something completely different. And I'm a pathologist by training. So I love medicine. I'm fascinated by the human body. And so we're developing a technology here to be able to understand it better. I'm one of the most humble people in believing that we are not perfect, believe it or not. As human beings, we make mistakes, but that's a problem in medicine. It's a problem because we can't make mistakes. We're talking about human life, and we need to get it right. And so when we went in with this company, Anatomy Next, it was about minimizing those mistakes. So next slide, please. Or do I have a controller up here? I'm sorry. Let's see where it is. Here it is. Okay. So okay. So the market for this technology, there's about 15 million healthcare professionals worldwide, and of that is about 2 million medical, dental, and physical therapy students. The average tuition for those students is about $50,000, and there's about 2,600 medical schools worldwide. Of that, 26 billion market. There's about 1.5 billion in the anatomy software market. And so the problem is that there's this is the essence of the problem. This is the accessibility to actually accurate visualizations. When I went to school, I look at some of these books now, and I'm like, wow, this was not accurate at all. I mean, it's amazing drawings, it's amazing textbooks, and I look at now what we're able to show you. I'm going to show you some examples, and maybe you'll see maybe how that is different. But it's the idea that the university medical education, it uses these materials enough, and they're 2D, and now we're finding that being able to visualize something in 3 dimensions, being able to manipulate it, to be able to actually control it with your hand, and have those annotations, you learn better. It's just the way our mind works. And so a lot of the software that we have is outdated and ineffective. And so, many studies show that, I just came from a meeting in Chicago, and it was clearly the case, and it's like 5 to 1, that the digital technology and digital media is the way to actually teach students better. And so, our business model with Anatomy Next is we're looking at 25 medical schools now. Each school about 100,000 for each school, and that's this is the revenue model for. Of the other speakers earlier today, was like, well, we're very small. But at the same time, this is quite important. And so, just to show you a little bit, and so if you look at these two, and you can see that the top is actually is a rendering of actual real human brain. Now, hopefully, I'm not grossing anybody out, but to me, this is amazing structure. This is the human brain. And so, one is the actual. You could see below how it's the actual. Structure in. Oops, that's the wrong thing. Yellow button. Okay. So the idea is that these are very close to structure. One is augmented reality, and one is the actual. So this is an example that it's cross-platform, that you can look at. You can have it loaded into a mobile telephone. You can look at it as a mini pad and as desktop. And the idea is that it's web-based, and so you actually be able to look from any platform, and that makes a difference between some of the competitors, whether it's Apple-based or Microsoft-based, and so it doesn't matter. There's mobile apps for looking, and I would encourage those of you who got it, so it's a free download for Neuro Anatomy Next, and you can actually study cranial nerves, and it's actually a good parlay into what the learning anatomy for any level of student. You have both expert and basic understanding. And this is just to show you how that it looks. I mean, this is just this is created from an actual living person. So that's the difference between a lot of the software that exists today, or a lot of the tools that are being used in medical schools. When I went to school, it's all about cadavers and dead people, And I think we should learn from living people, or living models. And so this is actually just showing that in augmented reality. And with this, and I'm not going to bore you with the details of it, but we're going into the head and neck, the cranial nerves, the muscles, and this is everything that you need to know in medicine. And so, we need to know insertions and origins and actions and innervations. And this is something that the software does, and we'll be able to rotate this. And in a second, I'm going to allow Dan, our AV guy, to have some fun with one of these, and then we'll see what he thinks. So this video didn't come up, right? So we're not able to load it. Anyway, I wanted to show you how we can rotate that, but I think we'll be able to do it with this one. Why don't you try that, Dan? And so what we're looking at is basically he's able to take the mouse and he'd be able to rotate that. You should be able to rotate it 360. Rotate it to understand every single one of these. And again, you can see this. O is the origins, I is the insertions, A is the actions, and we also have innervations, and you can click on any. And this allows reinforcement. Because again, it's a problem in medicine. If you don't know your craft, you don't know what you're working with, then mistakes happen. And this is kind of what we're trying to avoid. As you can see, this is a very high definition, very high quality type of models that we're working with, and that's the difference. And Dan, you're having too much fun. Let's go on to the next one. It's fun, though. You see, that's the idea. I mean, it shouldn't be a burden. And here we're looking at the lymphatic system. You can show, just click on the same way. You can zoom in. It's a little bit hard to see because this is floral enhanced, and this is quite critical, actually, to understanding the lymphatic system. And it's underappreciated, and it's not well taught in medicine. I could say that from my own experiences. It's very important as a pathologist to understand, say, if they're doing a surgical resection, and then they need to know whether that lymph node is involved or not, or what to remove and what not. I'm giving the call to the surgeon to say, yeah, you got it, all right, you can stop, because those networks are important for your overall immune functionality. So this is I would say, a fantastic advancement. When I look at models like this, I can become very excited, because this is exactly what needs to be taught in medical schools. All right, Dan, you have too much fun. Let's go to the next one. and again, this is, teaching them, showing them, oops, going too fast. So we have this, I won't go into all the details. This is, again, a simulated heart. We're able to understand certain different pathological conditions. You can have this beating, and this will beat real time, but in cardiovascular medicine, so it's understanding how the heart works, all the functionality, and you can begin to imagine how this could be important. And say I could tell you that there's approximately 567,000 patients last year just in the U.S. alone for cardiovascular maladies. So this is something that could be potentially used for physician-patient interaction, explaining exactly, okay, we're going to be looking at this coronary artery, you have an obstruction there of 30%, and this one is more of a problem. This could lead to a heart attack and a cardiac infarction event. So these are the sort of things that why these models and these sort of simulations are important. Here in dentistry, and unfortunately I can't rotate this, but in our model you can actually show this. Imagine with the patient, if you're talking to your dentist, okay, this incisor here is involved, and it needs the root that needs to have an endodontal treatment there, and this needs to be done. And I think that alleviating anxiety is quite important in medicine, and I think we need to address that a little bit more, not just like, sure, as the doctor showed, look how good I am, look what I can do, but to really talk to the patient about what's important. And so teaching it from, again, anatomy perspective and understanding and sort of laying those fears is very important in getting treatment. There was a lymph. I think that was, this was the whole idea that, immunology, cancer, this is all very important in terms of pre-surgical planning, reconstruction, and treatment optimization. This is just some more from the website where you can actually dive down in and look at some of these structures. And just by rotating the scroll bar, you can actually go down into, you can actually see what the innervations are. And again, cranial neuroanatomy is complicated. And even I don't suggest that I know absolutely everything about it, but this is fantastic to be able to put it all on paper and be able to help others facilitate that. So we, again, make less mistakes. And this is just explaining exactly how it is, and it separates it into different aspects of it. And again, it's a teaching tool. So this is something maybe you guys saw in the other room. Sandus and Jonas were explaining how you can actually have on a mobile phone be able to, in 3D dimensions. Probably all our new business cards will be able to, oh, it's a 3D holographic representation. Again, our mind works in such a way that it's better to learn in that sort of platform. Oops, I need to go back. But 1 minute, I got you. I'm on the second to last slide. And so this is the HoloLens technology. If you imagine how this can be used again in three-dimensional space to actually look. And what's interesting about the HoloLens is you'll be able to have these infrared interactions and actually be able to visualize and do overlays. And this is actually a fantastic aspect of the technology as well. So the possibilities beyond teaching are pre-surgical simulation in 3D space, as I mentioned, the HoloLens, tool for patient-physician communication, prosthetics, reconstructive surgery. You can actually print 3D body parts with this, no problem, really. And inaccurate, because before that was not possible. So continuing medical education is important, that we continue to learn, get better at our craft. Remote triage, you actually be able to have somebody who's not a physician be able to treat somebody just by the telemetry through the lens of the HoloLens. And again, to save lives and reduce errors and in clinical practice, because this is a problem, and we need to practice, and we need to simulate, and we need to get better. This is just some of the programs that have in the very illustrious list. One of these are the PAC-10, Stanford, USC, University of Washington, Colorado. I think the speaker really enjoyed the Buffalo. So even though they recognize it, this is just the team of individuals. And if there's any questions, I would welcome them. Thank you.
This is very interesting. I have a couple of questions, but we're going to leave it to the end to see if we have time. So we left the best to the end from that.
Thank you. No, Chris and Paul, that was very fascinating. When I went to pharmacy school, they said we were fortunate because we didn't have to learn anatomy through a textbook. We got to work on cadavers. They smelt, but at least we could touch them. Well, I wish that we would have had something like this because we could have studied 24 hours a day on cadavers. Good morning. It's really an honor to be here and to share the exciting work that we're doing at Prevencio, as well as hear the exciting work that's going on in the region. So thank you. We are a Kirkland-based company, and we are developing blood-based tests. So many people are often surprised to learn and think about what disease kills more people in the US than all cancers combined. You probably guessed, cardiovascular disease. And Prevencio is really focused on finding the diagnostic solution, improving the diagnostics for cardiovascular care, because right now they are substandard. We are using machine learning with multiple proteins to improve cardiovascular diagnostics. And our data shows that we're significantly more accurate than the standard of care stress test and the clinical risk scores. So if you think about what's going on in the world of medical technology, we've all heard plenty about genomic tests. And part of that's because the human genome was sequenced in the early 2000s, and the data was published, and people started to develop genomic tests. And it really led to some wonderful advancement in the diagnosis of many diseases, mainly oncology. We haven't done a lot with proteomics in cardiovascular medicine. But the reason I'm really excited about Prevencio is because we're focused on proteins. And proteins are really critical to understanding the disease. We're born with our genes, our DNA. It doesn't really change much. If you're exposed to a bunch of radiation or other things, you might mutate it. But it's really those genes that are giving your body the information to produce your proteins. And it's those proteins that will more readily change as you subject yourself to the world. As you eat poorly, it'll show up in your protein levels. As you don't exercise or anything, it's just not cardiovascular medicine, but most of diseases will show up with aberrant protein levels. So we have 2 fast, accurate, low-risk, multi-protein blood tests. The first one is for obstructive coronary artery disease. And as Paul showed you that graphic, I couldn't have asked you to have done something better. He showed us a side cut of the heart, and you saw those arteries that were on top of the heart. Well, the coronary arteries are the way that the heart gets blood. So the heart pumps blood to the rest of the body to give it oxygen, but the heart needs its own source of oxygen, and that's your coronary arteries. And, oh, that's not good. Okay, push the bottom one. Thank you. So when your coronary arteries are occluded, it's called atherosclerosis. It's when you eat all that bad food and you don't exercise, they get congested. And when they are about 70% or more obstructed, you're running a risk of having a heart attack. So this test will really help doctors understand if you're at imminent risk of having a heart attack. Our second test is for a 1-year risk of having a heart attack, stroke, or cardiac death. So if you or a loved one has chest pain, what do you immediately think? Heart attack. And sometimes it is, and you need to get the proper care at the proper time. The challenge right now, as I said, with the current diagnostics are anywhere from 30 to 65% of the people that are worked up on the current diagnostics, they're being sent to the cath lab needlessly, meaning that they don't have 70% obstruction. And I'll tell you why you really don't want to go to the cath lab if you don't need to. So if you have chest pain, we've got about 8 million patient visits to the emergency department in the US alone every year. You come in with chest pain, they will immediately put an EKG on you, and they'll do a blood test for a single protein called troponin. Troponin is released from your heart cells when you're having a heart attack. So these 2 tests are really good tests. They're standard care. If they're positive, they'll get you right to the cath lab because you need to get your coronary arteries opened up so that you are minimizing the amount of death that you're doing to your heart. The problem is, so we've got about 1 million of those a year. The problem is about 90% or 7 million of those 8 million patients, those tests are not positive or they're inconclusive because you're not having a heart attack. But we still really need to determine, are your coronary arteries obstructed? And right now, what they have are exercise or nuclear treadmills with something called a coronary CT angiogram. And again, these tests, they're at least tests, but there's a lot of false positives which lead to that 30 to 65% of patients needlessly going to the cath lab. And unfortunately, there's a lot of false negatives. So what we are looking at is to improve the diagnostic accuracy and get the correct patients to the cath lab if they really need it. We spend about $8 to $13 billion a year working up these patients, and I'm not going to go through all this data, but bottom line is on these tests, they're expensive, they're inaccurate, they're exposing you, many of them, to ionizing radiation, which can cause your genes to mutate and cause cancers. And if you go to the coronary cath lab, especially when you don't need to, you run a 1% risk of dying, you run a risk of having a heart attack, having a stroke, or having your kidneys blown out by the dye and going on dialysis. So again, you really don't want to go to the cath lab if you don't need to. And our solution, it's branded under HART, the HART test. They're both low cost, low risk, multi-protein tests. They are run on an immunoassay analyzer. These are analyzers that are available in most hospitals. So we're not selling a big platform. We de-risked our company by not developing a platform, but using commonly available platforms. And we're really focused on combining that machine learning with multiple proteins to develop accurate tests. And the two tests, again, is our diagnostic for that obstruction is HART, CAD. It's made up of 4 proteins. I won't read them, but you can. And again, it's significantly more accurate than the standard of care stress test. Something called an AUC of 1, it stands like for 100. A coronary cath will tell you 100% definitively if you have obstruction in your coronary arteries. We had an AUC of 0.87, so you can think of it almost 87%, 90%. The treadmills had an AUC of 0.52. It's like tossing a coin. So highly inaccurate. Our 1-year test also had 97% negative predictive value. And the whole value proposition is instead of waiting 6 to 24 hours to maybe get a treadmill or CT angiogram, people want to know right away what's going on. And if they can have a 1-hour blood test, it would be a significant value. So again, we feel that we can fit right into the emergency department, and actually in your annual physicals, you can get both tests and have a high assurance that you're either needing to go to the cath lab or you don't. We've had a number of clinical trials and partnerships. Mass General is where most of our data has come out of. On the diagnostic side, we're very pleased. We were accepted and presented as late-breaking science at the European Society of Cardiology. That data was published in the world's leading cardiology journal, the Journal of the American College of Cardiology. And our 1-year risk data was presented this year at the American College of Cardiology and just published in the American Journal of Cardiology. A lot of words. Our principal investigator is world-renowned. Do we have 1 minute, 30 seconds? Oh, we can finish. We've got a massive market potential of $6 billion, a lot of partnership opportunities, a couple different ways to go to market. We're hopeful to be able to offer pharmaceutical companies an LDT test inside of a year. We have raised less than $7 million to date, all from area, pretty much local area, high net worth individuals. We're getting ready to open up a Series C $15 million round that will help us develop the kit and do our regulatory trials. And dream big. This is Eastside Leadership Conference, right? So my leadership lessons include dream big, believe in yourself and a higher power, definitely persevere, keep abreast of emerging technologies and trends. So it's great to hear what's going on around here and to be grateful. Thank you. I'm very grateful to be here today.
We don't have time for any questions, but you can find them over lunch and ask them any questions. Really interesting, I think, all of them. And the interface between technology and medicine. I have a lot of questions, but we have to end and move to the next session. Thank you. Thank you.